Top Bed Talk.
This piece is part of a continuing conversation, and if you'd like to hear the first two parts, all you need to do is check out the show notes for more details. It's presented by Desiree Chappell with her guests, Jim Grant, Senior Vice President and Chief Medical Officer at Blue Cross Blue Shield of Michigan, Mike Englesbe, Professor of Surgery in Michigan, Linda Groah, CEO, Executive Director of the Association of Perioperative Registered Nurses, and Amy Stout, Operating Partner at Cranemere and Interim President, Clinical Services, NorthStar Anesthesia.
So next up, we are going to be talking about delivering value and how we do that. And we'll go ahead and start taking some of our questions. Next one is, do you get any credit for the lingering population health benefits? And, Mike, you talked about this earlier. Jim, is that something that payers are looking at?
I'd say payers are open up to all kind of creative payment programs. I think what payers are actually looking for is bringing value to the table. It's no longer, it's do X and get Y. It's what are we going to do to get Y? How are we going to get to Y? I can only speak for us as a payer, but as Mike will probably tell you, we're always open to new and innovative ways of doing things. Most of our, especially on the professional fee side, most of our increases now are associated to some kind of value, what we call value-based reimbursement. And the days of just automatic increases are gone. It really is proving how can we do things better for the patient, better for the health system, better for the customer. That's what we're committed to, and we're always open to new innovative ideas on how to do things better.
I just want to build on what Jim does. Really, I think, once again, I only know the state of Michigan, but, the incentives for are tied to the collaborative work that we do, and essentially the physician community sets what the incentives should be. We measure it. So I think, best care comes from nurses and doctors and patients. And we are trying to align pay for performance, value-based reimbursement incentives around population health measures. I do liver transplants. That's a good thing. The average liver transplant adds 7 years to someone's life. That's why I like doing it, I guess. That's for a 40-year-old. If I get a 40-year-old to quit smoking, I'll actually add 10 years to their life. So, we just kind of have to recalibrate kind of how we think about value. But our system isn't really set up for any of that kind of work, and that's going to be a long haul. But when you talk to nurses and doctors about things like that, they get it, right? It's a long haul, don't get me wrong. But I think if we can start to kind of align incentives for that type of care, then that'll be kind of a great thing for our patients. My other little soundbite is that, healthcare only contributes about 10 to 20% of someone's longevity. How long someone lives in our society is pretty much determined by social determinants or health behaviors. We as nurses and doctors have very little impact on that. And I'm going to start ranting big time, but in the United States, it's particularly a problem. For the first time ever, a population is living less long than they used to. It's never happened before. And if you were born in 1980 in the United States, your longevity was the same as in France. It's now 5 years less. So this is foundational health, and I think that's the new high-value perioperative care is affecting that. But the system's going to take a while. But I think purchasers, people who pay for healthcare, are going to start to demand this, and hopefully that we can innovate our system to catch up to it. So,
Amy, I'd love to get your perspective on this. As again, when you have been advising healthcare systems and kind of the whole system as a whole, what is your thought? What are your thoughts on that?
At least for the first time that I can remember in being in healthcare in the last couple of years, there is so much talk about and realization around, we can do what we can do when we have the patient. There's so much that goes on, whether they have access to food, access to transportation, all of the things that happen outside of when you see that patient, that are going to impact, their overall health and longevity. I think it's interesting and really important to think about then how does that translate into what we're doing in perioperative medicine, and how can we make sure and capture the great things we're doing that might help with the things that happen down the road. Whether you're teeing up some of the preventative things that the patient should be thinking about in your pre-op consult around smoking cessation or other things. So I think it is really important. And I do think it has more mind share and attention than maybe it has had in the past at sort of all levels of healthcare, which is, I don't think we solved our healthcare GDP problem in the US or anything else without really digging in and thinking about these social determinants of health and how as a whole system, not just a health system, but as whole communities, whether it's the payer, the local, the local churches, you name it, like really figuring out how we can kind of tie these things together to better manage all of the health for a patient.
Yeah. And Linda, do you have any thoughts on this? Because I think your perspective, again, from that executive level in the hospital would be a good one.
Well, we're actually, as an organization, really focusing in on the social determinants of health. And, we have such a short time frame to make a difference in the surgical patient's life. If the decision is not to do surgery until they stop smoking for 2 weeks or something, that is significant. That is a real change that they have to participate in. And so, but is it going to last? They have surgery and then are they going to go back to smoking? We don't know that. And so I think that just continuing to put the emphasis on the wellness. I really didn't know what Mike brought up about the length of lifetime being shortened. That's pretty incredible because we've had such a focus on wellness over the last 5 years. Particularly, I would say, ever since we've been focusing on that, and now with the social determinants of health, it does bring everything to the forefront that these things are important. What is their diet? And maybe they have a really good diet. I know that there are some. I've heard some patients say, "I love coming to the hospital because I get good food." That's a significant statement when you hear something like that from a surgical patient. So we have a very short window in time to try to make a difference. And I think we can only hope that any kind of referrals that we can do or any way that we can impact their life. But it's the clinicians that need to understand that. And I'm not sure that clinicians always look at the entire patient. They look at what they're focused on, and they don't look at the impact of what that has once they're discharged or they no longer have a post-op visit in their future. So it's a very complex issue, but looking at this from the multidisciplinary approach is absolutely the only way we're going to be able to make a difference in that surgical patient's experience.
The next question is from Karthik, and it is, how long before and after surgery are we invested in managing? Okay, that's a great question because we just talked about the definition of perioperative medicine is from the time of contemplation until full recovery. And Mike, I will start with you as the surgeon. How much are you invested? Okay, I shouldn't say you because you are yourself a special breed, but in general, surgeons, what is the typical time frame that you look at?
Do you want me to wear my aspirational hat or my reality hat?
Let's talk about reality first. All
right. Well, I try not to. There's a reason you become an academic, so you can avoid reality. So I think surgeons, depending on the care that you give, I think surgeons kind of view it in chunks of somewhere between 30 and 90 days. I think the average time in the state of Michigan from decision for surgery to when it actually happens is about 3 weeks, 3 to 4 weeks, longer than you might think. And I think surgeons kind of feel ownership during that time. And I think anesthesiologists probably less, but it really depends on the care model. Sometimes they're very involved, depending on the case mix. And then, most patients statistically are recovered, depending on the operation, between 30 and 90 days. So I kind of view it as like a 90-day window. And I think it's naive to think that when we talk about aspirational things like long-term foundational changes to health, that anesthesiologists and surgeons are going to, quote, carry that football. Like, that's naive, but systems of care. And I just have to plug what Amy said about the community-based care, which I'm really just learning more and more about. And that's where the secret sauce, I think, is going to happen. That's where a lot of the high value aspects of non-US based healthcare live, that we just don't have an infrastructure in the United States. Or if we do, it's through charities and churches and stuff like that. So to answer your question, Desiree, I think surgeons think between 30 and 90 days. That's how long they are kind of, quote, responsible.
Yeah. And Jim, anesthesiology?
Desiree, I think one of the issues that I was thinking about that question is we're used to very black and white terms. We pay our taxes on April 15th. We celebrate Christmas on December 25th. I don't think there's a clear-cut day. So if we were to actually going to say something, I'd probably say until our time has really ended. I mean, I know CMS gives us, global periods, and they've already determined it's, 30 days, 60 days, 90 days. But I think it's when you return back to your normal baseline, normal activities of daily living. I think pretty much that's when we're finally out of the picture. To some degree, some patients may need more help along the way. Some, the minute you discharge them from the back door, you never hear from them again because things are okay. I think it's really, really patient independent. But I think it's really when you get them back to how life was before this event started.
Yeah, for sure. What about, there's been this huge movement. A lot of people, when they consider perioperative medicine, they're really thinking about preoperative, interventions. And that's where the focus in anesthesia has definitely gone to. How do we as anesthesia get our hands on patients, beforehand?
That's actually a really good question, Desiree. And I think that's going to involve, and I've learned it in the two institutions where I led anesthesia departments, it really is going to involve collaborative relationships with nursing and with the office. And I used to always say, especially, we all know surgeons that used to hold cases back to board or phantom boardings. I used to tell them, come on, the minute you know a case is going to be done, let us know so we can start the prep. So we can see, do you need a cardiology evaluation? Do we need certain specific labs? Can we sort of scout these things out? I was at the point in some places, and it worked. You tell us the patient needs surgery, and we'll actually give you the right date for it. We know your block. We know when the patient's ready. We'll do the date. So there's all extremes. So, we're just doing an evaluation to really taking care of that whole preoperative care, the antibiotics, the getting the families there. I mean, I always like to laugh when you sit with a patient and talk to them for an hour about, and we don't think of these things until we're there, and you talk about risk of stroke and risk of this and risk of that. And at the end, you say, are there any questions? Yeah, where do I park? I mean, there's so much that goes into it. There's so much that goes into it that the more heads up they can give us, the better we can prepare the patient.
Yeah. Where do I park? Where's the cafeteria? That's it. Yeah. We have a couple more questions, and I think we should just go ahead and do those. So what's the key point to start a perioperative medicine program in a low-income country with no incentives at all? How do you approach the financial hospital department? So how would you approach that? And, all of us, I mean, I don't think we're working necessarily in a system that has incentives all the time. I mean, I think they're a unique situation. So I think, we could probably answer that question. Amy, from your perspective, what are some of the recommendations that you can give?
Yeah, I mean, I think, those circumstances probably in a lot of ways make it challenging because there's probably even fewer resources than we often feel and see in some of the countries of folks on the phone. I mean, I do think it is going back to a lot of the stuff that we talked about, which is, one, spending time to really learn from, this group and other colleagues who have started. So really understanding what it takes. So can you actually articulate for your hospital, like, if we're going to do this, this actually means we have a pre-op clinic and we need to invest in these types of resources. I also think, I bet if you talk to most of the folks who've done this, there are ways to stage it. There are probably components of a perioperative medicine program that could be starting components that you can build on over time. So I guess my first piece of advice would be to tap into this network and really kind of learn, what would a phase one program look like? I think that's important because then you can approach your hospital team and say, this is where I want to start. Ultimately, we might build on it, but let's start here. And then as part of that, I would also think through what things can I have in mind from the outset that I can try and kind of keep track of to some extent that will help the hospital or system understand that this is a good thing to focus on. So whether it is things, that lower complications for the patients after the fact, or that they got home much quicker than they otherwise would have, keeping track of those things and sharing them back, having been an executive, at a company for a long time, that's how I would make decisions about things. Are there good reasons to do this? And are we actually seeing it come to fruition? And so just really thinking through those things at the beginning and starting the conversation, I think could be really useful. The last thing I'll say, and then I'll let someone else chime in, is it might also be good to, if you're kind of going down this road, again, tapping into this network in a different way. So can you put some of the clinical leaders on the phone that have done it with some of your hospital to give them confidence that, yeah, this is the right answer. You can make this happen. And so those are the things I'd think about.
Yeah, that's great. Mike, I don't know if whenever you started your journey, if it was incentivized or how it's technically even incentivized at this point, but I'm sure you have some insight into this. How would you recommend someone, would start a program like this?
Yeah, I don't know if I do. I'll take a stab at it, but it's a great question, humbling. I describe my practice model as I work in the Soviet Union, but there's lots of resources and it's highly functioning, so it's not the real world. So I don't know if I have enough kind of lived experience, but I'll take a stab. I think I'm saying the same thing as Amy. Ask kind of the organization what the biggest problem is. There's infinite problems that we can chisel around and have them kind of, just prioritize and then try to fix one. So for example, most of the resources that I'm able to kind of justify within my organization are related to the fact that we run at capacity, and reducing length of stay is a big value proposition. So, and it could be, and integrate that into your perioperative program. So we have a very robust prehabilitation program. Everyone prehabs. And that is because our organization firmly believes it's the right thing for patients and it reduces the length of stay. So I guess that would be my answer. In a low resource organization, there are kind of pressure points, no doubt, and try to kind of fix two problems at once, make people better, and try to fix the system problem within your organization. And that would be my advice.
Yeah, that's great. Linda, very quickly, because there's two more questions that I want to get through, but you represent, you've come from like Kaiser and lots of resources there, but you represent in the AORN probably those without, as many resources. So what would be your recommendation?
Well, Amy has really, I think, hit a lot of the high points, but I think a group that's committed stakeholders are really important, multidisciplinary, that come together, that are committed to the outcome and understand the program and the roadmap that they're going to have to travel in order to have the outcomes that they're looking at. But what are their vulnerabilities, and focus in on that and look for short wins and then build on those. And I think Amy really highlighted a lot of that.
All right, two more questions really quickly. Hello from Ireland, and Padraig, I am so sorry. I cannot speak the language at all, but thank you from Ireland for your question. Very quickly, what does the panel feel that are the main barriers to perioperative medicine at a ward level? So, getting it out onto the floors. Mike, I'll start with you. Kind of what do you see are the challenges whenever you've dropped, the patients now through their surgery and they're on the floor?
I mean, there's too many to list, but I guess it's just transitions in care teams. Transitions in care teams, kind of like, challenges with technology. We have, my organization has a lot of trainees, so they're itinerant. So having kind of people who really know, like physician extenders who kind of live in that space, and they can make sure pathway driven care is followed. I think those are the biggest challenges. And I don't think any of us think much about care beyond the discharge. So trying to think about the patient beyond discharge. I guess those are my answers. It's a good question. And yeah.
It is. Yeah. And Linda, you may agree with me on this one from a nursing perspective, because I myself is from that. I think education for providers, the nurses, the care teams out there on the floors, the PCAs, making sure that they all have that education for them, and patient education as well. Would you agree?
Absolutely. And understanding the program so that they have the full scope of it, not just one piece of it.
Yeah, I think that's teeing up the value proposition for that group of people, as they want to know what the
exactly.
why is. Yeah, for sure. Amy, Linda, Jim, Mike, thank you so much for your input and your thoughts on this conversation this morning. You know, we wanted to try something new where we didn't do PowerPoints. We wanted to just have a nice flowing conversation. And I think we've done that. So really looking forward to the year ahead and other opportunities that we might be able to do deeper dives into the same topic, because I think we could probably talk all day on it. But anyway, thank you guys for taking the time out of your busy schedules to participate in that.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.